Thank you, everyone, for being here, and thank you for the opportunity. Also, thank you for the introduction. So today, I will explain my study about influence of serotonin in bladder bowel dysfunction. So first, I will introduce bladder bowel dysfunction, or BBD, then explore current concepts in BBD pathophysiology, highlighting the brain-gut-bladder axis. Finally, I will present our study about the influence of serotonin and serotonin transporter SERT using a mouse model, SERT knockout mouse, and its translational relevance. So BBD is a common clinical condition affecting approximately 40% of pediatric urology patients. The common signs and symptoms include daytime accidents, urgency, frequency, recurrent UTIs, holding behaviors, also constipation, incorporesis, and abdominal or pelvic discomfort. The diagnosis can be challenging because the symptoms may be underreported and the physical exam and imaging are typically normal. BBD often co-occurs with neuropsychiatric conditions, and that can cause physical and psychosocial distress for both the children and to their families. Besides that, it's costly to parents and the healthcare system. And despite being so common, the etiology remains poorly understood, limiting effective treatment options. So several factors may contribute to BBD. For example, a child who experienced pain from UTI begin holding the urine, leading to unhealthy bladder habits. Constipation can also affect bladder function. Stool in the rectum can place pressure in the bladder, interfering with normal emptying. As I said before, neuropsychiatric conditions are also associated with BBD. And recently, studies have indicated that prolonged diaper use and delay in toilet training may also play a role. So overall, BBD, several factors contribute to BBD. However, there's a gap in knowledge because the primary cause remains unknown. There we go. So studies have described the interconnected signaling between bladder, brain, gut, and microbiome. So the gut microbiome communicates with the bladder and the brain through a variety of signaling pathways, and serotonin is a potential link between these systems. In this study, they show the patients with overactive bladder often present depression and also IBS, and that 60% of microbes detected in urine are also found in stool, suggesting a close connection between gut and urinary microbiomes. So serotonin is best known as a neurotransmitter in the brain. However, most of the body's serotonin is produced in the gut and can influence neuropsychiatric symptoms, GI motility, urinary tract function, and can also influence the microbiome, and the microbiome itself can affect serotonin production. So we believe there's a link between BBD symptoms and serotonin. However, the connection between BBD, microbiome, serotonin signaling, and metabolites has not been investigated yet. So the central hypothesis of my study is that urine and feces from children with BBD have altered bacterial communities, including a decrease in serotonin-producing bacteria and serotonin metabolites, and that is potentially driven by dietary factors such as Western diet. So to address this question, we are using two complementary approaches. First, we are collecting urine and stool samples from children with BBD. And second, we are trying to develop a mouse model to study BBD. So we are using SERT knockout mice. They don't have the serotonin transporter SERT. So they have decreasing levels of serotonin and disrupt serotonin signaling. To analyze urinary and GI function, we are using Euroflow, avoiding behavioral by doing voiding spot assays. We are also doing bladder bath and behavioral testing to assess anxiety, depression. We are collecting tissue and sample collection, like a sample, stool and urine for microbiome analysis. And it's important to highlight that we include both female and male mice, and we are analyzing them separately. Our preliminary data indicated that certain knockout mice expressed NGAL in the urethral epithelium under basal conditions, meaning signs of inflammation, as you can see here. And following transurethral E. coli infection, female CERT knockout, they have increase in colonies forming units in the bladder compared to the female wild type. So this preliminary data indicates that altered serotonin signaling can influence inflammation. And also we have published that serotonin can also influence the urethral defense against ascending E. coli. And the male CERT knockout mice display features consistent with BBD, including decrease in body frequency, decrease in fecal pellet output, and increasing the voiding interval. So these findings suggest possible underactive bladder and a constipation-like phenotype. In the voiding spot assay, we did not find a significant difference in the urine spot count. However, the CERT knockout male mice, they urinate more in the center of the enclosure compared to the wild type and CERT head. And that suggests possible altered voiding control, urge urinary incontinence. However, we cannot take any conclusion based only on this data. Moving to the female CERT knockout mice, similar to male, they had decreasing voiding frequency and fecal pellet output and increasing voiding interval. So taking together both male and female CERT knockout mice, they had decreasing voiding frequency, increasing voiding interval, and decreasing fecal pellet output. In the voiding spot assay, only the male CERT knockout had increase in the percentage of urination in the center. And this phenotype is particularly interesting because children with BBD commonly have voiding postponement behavior, urge, and constipation. So moving to the behavioral data, the CERT knockout male mice demonstrated anxiety-like behavior. As you can see on the top, show the data from the Elevate Plus maze. They spend more time immobile and in closed arms, and less time in the center. And on the bottom is the open field test. And again, they spend more time resting in the periphery and less time in the center. The CERT knockout female mice also demonstrate anxiety-like behavior in the Elevate Plus maze. However, in the open field, no statistical significance was found. But in the Elevate Plus maze, it was similar to males. They spend more time immobile, in closed arms, and less time in the center of the enclosure. The Elevate Plus maze, sorry. So overall, male and female CERT knockout mice have anxiety-like behavior. However, the open field, the female CERT knockout, there was no statistical significance, possibly because we need still increase the number of females in the study, and also could have sex difference. So still we need included females to make sure we know what's going on. And this is relevant because neuropsychiatric disorders often co-occurs with BBD, and children with more severe symptoms have been reported to have higher likelihood of underlying neuropsychiatric conditions. Moving to the histology data. So here's the hematoxylin eosin staining. On the bottom is certain knockout prostates, and on the top is wild type. As you can see, the certain knockout prostates appear to have thicker small muscle layers compared to the wild type. However, additional quantification is required to confirm hypertrophy. In the bladder, again, here certain knockout on the bottom and wild type on the top. Certain knockout male mice appear to have thicker small muscle, the detrusor small muscle layer compared to the wild type. And one possibility is the thickening of the prostate small muscle in the certain knockout mice may contribute to the bladder outlet obstruction and could potentially drive secondary bladder muscle changes, but we still need to quantify and small muscle thickness and count the nuclei. In the small intestine, again, certain knockout mice, they have thicker small muscle layers and also cellular infiltration, possibly inflammation, compared to the wild type. And in the immunohistochemistry, we can see the certain knockout male mice have decrease in serotonin signaling compared to the wild type. Here you can see the same. And also have decrease in serotonin receptor 4 expression, as you can see here. And that's consistent with a constipation-like phenotype. Moving to the bladder contractility. So I have just a really preliminary data about that, but I think it's important to show here. So the preliminary data suggests no difference in K-cell-induced contractility response between the groups. However, the preliminary data suggests an increase in carbachol-induced contraction in the female certain knockout mice, but as I said, it's still just a preliminary data. Next, I'll be doing cystometry, bladder bath studies, gastrointestinal transit measurements, stool water content analysis, and also urine and stool microbiome and metabolomic analysis. Moving to the human subject part of my study. So again, the hypothesis is that urine and feces from children BBD have altered bacterial communities, decrease in serotonin-producing bacteria and serotonin metabolites, potentially driven by dietary factors. So we are recruiting children between 4 to 17 years of age with BBD and age-matched health controls. We are excluding GU and GI abnormalities and recent exposure to corticosteroids, SSRIs, antibiotics or probiotics, and also children who are not toilet trained. We assess urinary symptoms using the Dysfunctional Voiding Symptom Score, DVSS. It's a validated questionnaire developed by Dr. Farhar and colleagues. So we consider high DVSS score 6 or higher for females and 9 or higher for males. So the questionnaire is really easy and simple to understand and contains 10 questions about voiding habits. And we assess bowel symptoms using Rome criteria and stool consistency using the Bristol Stool Scale. So for the children being the BBD group, they need to have high DVSS score and meet at least 2 of the Rome criteria. And we also quantify constipation severity using the constipation scoring system developed by Santos and colleagues, which captures symptoms frequency and severity. So the participants collect urine and stool samples at home, and then the samples undergo microbiome sequencing and metabolomic analysis, including evaluation of metabolites involved in tryptophan serotonin pathways. After 1 year of the collection of the samples, we send a survey, a follow-up survey, to assess UTI occurrence and symptom severity. And then we correlate the biological data with the clinical symptom scores and dietary information. So here's the workflow. So first, the participant will receive a red cap link or a QR code. And then if they're eligible, a DVSS and bowel questionnaires open up automatically. If they're not eligible, a thank you message will display. For the eligible participants, we call the parent, the guardian, and we obtain assent. And after that, we send the consent form and the lifestyle questionnaire that contain questions about nutrition habits, sleeping habits, and also exercise habits. And after they sign, we mail the collection kits to the patient house. They collect the samples and they mail back to the lab. And then we compensate the participation, paying $50 per child. The recruitment is ongoing through the urology clinic at American Family Children's Hospital and also via UW research email. To date, we have 32 participants, and we are also adding a new recruitment site in the Morris Children's Health in Jacksonville, Florida, because we want to capture more heterogeneous BBD population. And we are also developing a qualitative arm of this study because we want to better understand the parent experience, especially for kids with neuropsychiatric disorders. So here's just the preliminary data. From 32 participants, 15 had high DVSS scores. And it's really interesting because most of the parents did not report urinary symptoms. Instead, they report only bowel problems or no problems at all. So this suggests that urinary problems in children with BBD may be overlooked or under-recognized by caregivers, and similar to what is found in literature. And the females were the majority of the participants with high DVSS scores, consistent with prior studies reporting a higher prevalence of BBD among girls. And higher constipation scores were positive correlated with high DVSS scores, later potty training, and Rome criteria scores, also similar to what is found in literature. So this preliminary data supports the close relationship between bowel and bladder dysfunction. And to conclude, I think the aim of my study is to define microbiome metabolomic patterns linked to BBD, but focus on serotonin. Also supports the development of target microbiome-focused therapies and identify potential dietary intervention. We also want to improve the diagnostic, reducing unnecessary testing, and the main future goal is a personalized approach to pediatric urology care. So I'd like to thank you everyone that's involved in this study and also my funding. And I'm open for questions and suggestions, feedbacks.